the neurological examination we're going to demonstrate is a way to confirm the basic hypothesis that was put forward on the taking the history. The mechanisms that will be shown to you will sometimes vary from physician to physician, but this is a basic way to do the neurological examination that will give reasonably reproducible results. I'm not going to do the higher mental examination, which is the first part, but we'll start with the cranial nerves, and we take them in the usual order that they will be examined, not necessarily numerically. Right, so if you start off with the first cranial nerve, it's important that sensation is sometimes tested, and if it's done in the correct way. Remember that it's a basic principle in neurology that we compare left to right, and other patterns of deficit, either motor or sensory, will be clear as we proceed. Right, so if we start with the first, or the olfactory nerve, it's for smell, and the way to test this is with test objects. It's important, if you use a test object, that it should be an aromatic substance such as a fruit or coffee, and we test one nostril at a time. It's important to be sure that the air passages are patent, so we ask the patient to sniff, do that, and sniff on that side. Right, and then we keep the object away from the patient. We ask the patient to close his eyes, so close your eyes please, and then we ask him to sniff whatever object we're testing, and the patient will either smell it, if it's a male, and if it's female, will possibly be able to also identify it. Right, so that's the first part of smell, but it's also important to be sure that there is no obstruction, so we usually inspect the nostrils as well for patency. The second cranial nerve is probably more important, and the obvious deficit there is that of poor vision. So it's important to test visual acuity. Visual acuity is tested with a reading card. If a more formal approach is necessary, then a Snellen card is used, which is mounted 6 meters on the wall. But for neurological purposes, this will usually suffice, and we ask the patient to use his glasses as well. And remember, once again, it's important that one eye is tested at a time, and the patient is asked to read the best he's able to do. Right, so the visual acuity is recorded according to the figures given on this, but for the Snellen chart, usually 6 with denominator is used. The next part of the examination of the optic nerve consists of testing the visual fields, and this is a geometry test in a sense, that the basis of that is to compare the operator's visual fields with that of the patient. So once again, it's necessary to ask the patient to occlude an eye, and he's instructed to look directly at the eye of the visual, the examiner, who also has to close his one eye. It's useful to use a red test object, and the patient is instructed to look directly at the eye of the examiner. The test object is then approached from the external or the temporal part of the visual fields, and the patient asked to acknowledge when he sees it. Right, so there you should be able to see this object. Now you should tell me when you see it again. That's it. And it's tested for that quadrant, including the nasal quadrant and the superior nasal quadrant. So summary, all 4 quadrants for each eye will be tested separately. Right, then to inspect the optic nerve, the ophthalmoscope is used, and this is used in a way that will optimally disclose whatever information may be gained from inspecting the optic nerve head. We do not dilate the patient's pupils for neurological purposes, but usually to see whether the patient has pupillary edema is adequate to subdue lighting, which is helpful, but for the experienced examiner may be quite unnecessary. So the patient is instructed to look straight in front of him, to fix on a spot there, and for the right eye, the examiner uses his right hand and right eye. It's approached from a little distance away in a medial and superior direction, and that should be approximately the distance at which the vessels at first will become discernible, but then it's necessary to search specifically for the optic nerve head or the fundus, and then eventually the peripheral retina should be examined as well. And it's also done in the same way for the other eye, but again now with the left hand and with the left eye. So you need to close one eye, but it's usually quite easily accomplished with a little bit of practice. Next part of testing would be color vision, for which specific cards are available, but it's not routinely done. For the last part of the second cranial nerve involves the reflex activity, and for that adequate light source is used. And first, the pupils are inspected for size and symmetry, and by shining the light from below, the amount of light entering into the eye is limited. So it's merely to enable us to be able to see the pupil, which may be quite difficult in a dark-eyed person. And then the pupillary reflex is tested by shining the light directly into the eye, and it's done twice. The first is to have a look at the reflex in this eye, and then to see whether that pupil is also contracting. And then the same is repeated for the other eye. First for the pupillary reflex on the same side, and then for the consensual reflex on the other side. This also brings us to the next group of cranial nerves, which are grouped together, including the third, fourth, and sixth cranial nerves, and they are the nerves of ocular motility. The sequence to test this would, in the first instance, include examination of the pupils, but then it's also important to look for ptosis, and especially to ascertain the size of the palpebral fissure on the left and the right, and to see that it's symmetrical. The distance between the upper eyelid and the pupil is also a measure of the degree of ptosis that may be present. Eye movements is tested by using either your finger or a test object, and it's at least 50 centimeters distant from the patient. 10 positions are easily remembered, and the first primary position is probably the most important, as would be the lateral movement. So the patient is asked to fixate on that, and then it's moved first to either the left or the right, and looking at eye movements, pursuit movements, it is seen that it moves quite smoothly. There is no obvious deficit, and it's then necessary to deduce from these movements whether there is any paralysis present of either a lateral or medial rectus muscle. So that would be position number 1, 2, 3, 4, 5, 6, 7, 8, 9, and eventually 10. Right. Then the next a group of cranial nerves that are examined is the fifth cranial nerve, and that is a sensory nerve mainly. So we start off usually by testing sensation, which will be more clearly demonstrated later on. Second important function is that of the muscles of mastication. So the patient is asked to clench his teeth, clench your teeth, and then asked to show his teeth, and then asked to open his mouth. Slowly open your mouth. Open, open, open. And it's important to see whether there's any deviation by looking at the symmetry of the teeth in relation to each other. There are two reflexes that needs to be examined, and the first is the corneal reflex, of which the afferent is the fifth cranial nerve, and the efferent would be the seventh cranial nerve. So this will also bring us to examining the seventh cranial nerve. So the patient is asked to look a little bit sideways and upwards, and he's warned that by touching his eye there may be a little bit discomfort, and is then touched on the limbus area there of the corneal reflex, of the cornea, and it's noted whether there is contraction or closure of eyes on both sides. So it's also a consensual reflex, and for the other side practically the same applies. Right. Then we also do the jaw reflex, and the patient is asked to open his mouth a little bit, slightly, and try to relax that. And it's a downward movement rather firmly in the direction that the jaw will normally open. The seventh cranial nerve is examined by looking at the muscles of facial expression first, and the patient is first asked to look up, and we look at frowning of the frontalis muscle. Then the patient is asked to close his eyes forcibly and look at the difference between the eyelashes on left and right, and then the patient is asked to show his teeth again, and then also to contract these muscles in that way. That's the lowest part of the facial nerve supply. And then we also ask the patient to whistle, and the idea is not such to look at the whistle, but to see a smile that is invariably elicited by whistling. And then we start at the top again, look up, up, right, close your eyes, close strongly, and we try to forcibly open the eye, and you can see that it's in a normal person practically impossible. And we do the same for lip closure. Close your lips, right. We also have to remember that there may be auditory disturbances due to facial paralysis, so we have to ask about hyperacusis and also take into account tearing of the eyes. Testing of taste sensation is rarely done and needs to be properly done almost in the same way that was applicable for smell. But remember that basic tastes are tests such as sweet, salt, acidity, and bitterness. The next cranial nerve would be then the eighth cranial nerve, and it runs in close relation anatomically to the seventh cranial nerve, but it's important then to have an idea of whether the patient has involvement of hearing, and for that you can either use the rubbing test, where you ask the patient to include the other ear by pressing on that, the tragus area, and then asking the patient to report whether he's able to hear the rubbing sound. You hear that?
Yes.
Yep. Hear that? Tell me when it's gone. Close your eyes.
There.
Right, and the patient would usually be able to hear it up to his shoulder area. Or you could use the whisper test, where you whispering to his ear. Repeat that, please.
66.
66, or some other figure. It's then also important to inspect the external auditory canal, and for that otoscope is used, and obviously looked into the auditory canal. It's important to remember that the eighth nerve also has vestibular functions, so we once again have to check on the nystagmus, and especially rotatory nystagmus would be some indication of vestibular involvement. The next cranial nerve to examine would then be cranial nerves 9 and 10, and for that purpose, once again, an adequate light source is needed. Open your mouth. We then inspect the soft palate. The patient is asked to say ah, and we also do the gag reflex, first on the right and then on the left. Remember there are two sides. While we are there and we have the light in this spatula, we ask the patient again to open his mouth, and we inspect the tongue for atrophy, any abnormalities on the surface, and also fasciculations or other abnormal movements. The patient is then instructed to put out his tongue as far as you can, back, and remember that the tongue will deviate to the side of the weakness. We then also test muscle strength. Push against the spatula, no, with your tongue. There you go, and the left and the right. And then the patient is asked to do repetitive movements such as this, and say la 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 la, la 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 la, which will give you some indication of spasticity of the tongue. The next cranial nerve to examine is very much similar to the motor examination, and would be the 11th cranial nerve. So under this condition, we inspect for abnormal movements, as we would do for a motor examination, and any atrophy of muscles. We then proceed to test the muscle. Turn your head to the left against my hand, and the muscle can be palpated there and compared to the other side. We also test the trapezius by asking the patient to shrug his shoulders, and muscle is graded as would usually be done for all muscle strength on a scale of 5. We also test flexion of neck muscles, push forward, and then we ask the patient to push backwards. All right. Then we will proceed with examining motor functions in the upper limb, and it's necessary to adequately expose muscles to see the definition, to see whether there's atrophy of muscles, and it might be palpated to compare the left and the right. And intrinsic muscles are also examined, and the patient may be asked to clench his thumb, which will give you some indication of adequate muscle mass. The next step is to test the muscle tone, and usually 3 maneuvers are used for these. It's important to put your thumb on the tendon of the bicep muscle, which is then palpated, while flexing, extending the elbow through a varying range at different velocities to keep the patient from assisting in the movement, and left is compared to right. Then it's also helpful to test muscle tone at the wrist and compare to the other side, and also to test pronation and supination by a passive movement. Keep all other grips and any way you want to immobilize to such an extent that you won't hamper any movements in the upper limb. Then proceeding to actually test the muscle strength, the patient is asked to abduct the shoulders by putting his shoulders up. Be careful that the fists stay apart and is not supported on the body. Then adequate pressure is applied on vantage points, and the patient instructed to give resistance to gradually increase in strength. Then the downward movement is tested, adduction of the shoulder, and subsequently flexion of the shoulders, of the elbow, pull towards you. And what you need to note is that we always test a muscle in action. If a patient is in a disadvantaged position, we'll get the wrong impression of muscle strength. We'll show that to you in a second. Then we ask the patient to extend the elbow, and it's repeated on the other side. Now, if the patient extends his elbow in a maximally flexed position, you will see that he's a lot weaker than would be expected. Push again. You can see it can quite be easily overcome. So it's always in a position of maximal advantage to the patient. In action, that is the key, right? We then proceed to the wrist, cock your wrist, and patients asked to resist against that and to offer resistance to flexion as well. Compared to the left side, which is not done now because of the fact that we want to demonstrate the way to do this. Then extension of the fingers. Patient is asked to extend the fingers against resistance, and grasp is, or flexion of the fingers by asking the patient to grab hold of the fingers and squeeze. And you should not be able to pull your fingers from the patient's grasp. Then the intrinsic hand muscles are tested. Open your fingers, and the resistance is actually demonstrated by comparing it to that of the examiner in some cases. What we haven't done is to show you how specific muscles are tested, and sometimes it may be necessary to demonstrate, for instance, specifically should be able to see the muscle belly and feel it quite comfortably, and compare once again to the other side. It's important that the patient's cooperation is obtained, and if a patient has pain, there may be a problem, but remember that the first initial effort is often the maximal grading of the strength, and that is important sometimes to reassure the patient that only that is needed, and that you should cooperate as far as possible. Right, we'll get to this lower limbs in a second by moving, asking the patient to lie down. We follow the same sequence by inspecting for abnormal movements, any atrophy, also of intrinsic foot muscles, such as that, the extensor digitorum, and then we test muscle tone. And the way to do that is first by rolling the limb, getting the patient to relax, and then exerting a sudden jerk movement. And it's once again compared to the other side. And what will happen is that, in this case, the heel will elevate from the bed, but it will touch down quite quickly. Then test flexion at the knee by passively moving the joint, also varying the range and the velocity of the movements. It may be useful also to test abduction movements, and especially increase in adductor tone is indicative of spasticity. The sensory examination is done by examining or keeping in mind the main pathways of conduction of sensory impulses, and for that cotton wool is used, and it's important to test for specific patterns of sensory loss, which may be a sensory level, as you would expect of spinal cord diseases, and also keeping in mind root distributions such as L5 root, which may be separately involved. Sometimes necessary to test for specific peripheral nerves such as the median nerve and compare that to the ulnar nerve. Another pattern often found is that of glove and stocking sensory loss, as in peripheral neuropathy, and the patient is asked to ascertain whether there's a difference in distal sensation compared to the more proximal areas. We do the same for pain sensation, which is done with an office pin and not by any other sharp object such as needles, which may cause injuries. The next important thing is to test for positional sense, and this will test the dorsal columns. Now, it's important to move only one joint at a time. So the first phalanx is stabilized, and the patient is asked to have a look here and to tell whether the toe is moved down or up. Now, up, right. Lie down again. Close your eyes. Patient is now asked to close his eyes and tell whether the toe is moved down or up. Down, down, up, down. And another important point is not to exert pressure there or there, but to avoid any indication of where pressure is applied. And it's once again compared to the other side. Vibration sense is tested using a tuning fork, 156, and it's put into motion, and the patient asks first whether he's able to feel that. Yep. And then to compare, in a sense, the sensation to that. Yep. And to tell when it has disappeared, and then, if necessary, it can be done on bony prominences, also more proximally. The next part is then, after looking at the efferent and the efferent pathways, to look at the connection of these by testing reflexes. And this is done first in the upper limbs by adequately exposing muscles. Get the patient in a relaxed, symmetrical position. The thumb is put into the biceps tendon, and then the reflex elicited and can be seen to contract in the biceps there. If it's not all that easily seen or not felt, as one should do with the thumb there on the tendon, the patient is asked to clench his teeth, and then you can see that that actually enhances the reflex. The patient is asked to relax first and clench, and it's elicited. The brachioradial reflex is tested by a firm tap on the radial side of the forearm and the two sides compared. And getting the patient to relax, the arm is pulled across and the triceps reflex once again elicited. Sometimes a finger flexor reflex may be elicited, and this is done by looking at the thumb and the index finger, and with a firm flexing movement of the distal phalanx demonstrate hyperreflexivity by showing that there is adduction of those two fingers. That would only be a sign of hyperreflexivity. Then in the lower limbs, patient should be adequately covered, as when testing muscle tone, and the reflexes then done by comparing two sides, by picking up both together, and the patient is asked to relax, and you can see that the reflex is quite easily elicited. If uncertain, palpate the tendon first. Note that it's a bit on the lateral side there. Once again, if it's absent, the patient is asked to put his hands together like this, and only when on instruction asked to firmly pull them apart and pull. And you can see that the reflex now is more easily elicited. The same applies to the ankle reflex, and the lower limb is flexed into that position. The foot is then dorsiflexed, and it's useful to be sure that the patient is relaxed, and a firm tap will elicit the reflex. At this stage, because it's a reflex phenomenon, clonus is also elicited, if applicable. We would not expect this patient to have clonus, but patellar clonus is elicited by firm downward and maintained pressure on the patella in this way. And oscillation is the expected result. Ankle clonus may be elicited by picking up the lower limb or the heel from the bed, flexing the knee a little bit, and then with a firm movement with pressure on the ball of the foot, dorsiflex the foot and maintain the pressure. And obviously it is compared to the other side. It's not useful to elicit clonus in the upper limbs, but we still need to do some of the superficial reflexes, including the plantar reflex. This is done by using a reasonably sharp object, but not one that will cause unduly or unnecessary discomfort to the patient, and the patient is warned that he will be stroked on the ball of the foot. We start at the heel area, move up on the lateral area, and you can see that there is flexion at this joint. That is a normal flexion plantar reflex. It is only abnormal if there is extension, which is then called a Babinski sign, and which indicates upper motor neuron lesion. We then proceed also to do the abdominal reflexes, as this is also a superficial reflex, and it may be necessary first to elicit the deep abdominal reflexes, which in this patient is absent, but with spasticity or upper motor lesions may be increased. And then the superficial reflex is elicited by stroking consistently in a lumbar direction on both sides. You can see that there's a little bit of contraction of the abdominal superficial muscles. The important thing is that upper motor neuron lesions will cause increased deep reflexes with loss of the superficial reflexes. Next part of the examination is that of cerebellar function and coordination, and it can only be tested after making sure that the patient does not have spasticity, not marked weakness, and not positional sense, because all that may influence coordination and rapid alternating movements. So for examining cerebellar function, we once again think about nystagmus, that may be pendular. We listen to the speech of the patient, which may be explosive, and then we proceed to the upper limbs, where we do the finger-nose test. Put your finger on your nose and my finger back and forth as quickly as you can now. And we do that in different positions by also moving the test finger in space. And the same is done on the other side. We ask then the patient to perform rapid alternating movements for dysdiadotic kinesia, and he's asked to put his hands together like this and then turn the ball as quickly as you can. Quicker, quicker, quicker. Right, thank you. And then you do that. Write a circle on the palm of your hand. And you would do that to compare on the other side. Remember that muscle tone may be reduced in patients with cerebellar lesion. Then in the lower limb, the patient is asked to put his heel on his knee, move it down and up and down and carry on with that. Now I want it precisely on your heel, down, up and down. Right, and the patient is not looking at it. It also becomes a test for positional sense. We also may ask the patient to do rapidly alternating movements, and you will realize that it may be abnormal with either spasticity or with positional dysfunction as well. As the last part, before we get to the gait, because that is an important function, we also need to ask the patient or to think about autonomic dysfunction, bladder involvement, rectal incontinence, and also about hypertension and blood pressure changes in the sitting or standing up position. So the autonomic system also needs to be tested. It's important to test the gait, and it gives indication of weakness as well as coordination problems. Walk to the foot of the bed there, and then the patient is asked to walk back on his toes, and that will indicate that strength in the calf muscles is 5 out of 5. Back on your heels for the dorsiflexors of the lower limb, and then the patient is asked to walk on a straight line in a tandem way to test coordination and cerebellar dysfunction. The patient is then asked to face straight in front of him, put his feet about 2 centimeters apart, pick up his head, look straight in front of him, and it is then noted whether there is any swaying of a patient. He then closes his eyes, and it's noted whether there is aggravation of the swaying movements, which will indicate dorsal column dysfunction, and this is called Romberg's test, which is not primarily a cerebellar test, but there may be discrepancies when patients have cerebellar dysfunction as well. When testing gait, it's also useful to test lower limb strength by asking the patient to squat and go down and up again, and it may even be possible for most patients, at least without osteoarthrosis, to do that on one foot. And it's also an indication of balance capabilities of the patient. So this then concludes the neurological examination. There are different ways to do things, but as I've said previously, this is the way that will give you the most consistent results. And although there are other reflexes and other ways to do this, it is usually very rarely helpful to go beyond this. Remember also that the neurological examination is done in such a way that it will make a pattern more definite, clearer, by examining, for instance, reflexes, or examining the sensory system, or examining the motor system in totality, starting at certain cranial nerves, for instance, to discern whether there is motor involvement by testing facial muscles, muscles of mastication, and then proceeding to the limbs.